Hello, everybody. I hope you're having a good day. I just wanted to say thank you for everyone who've been following my videos, and I hope you're getting some value out of it. Now, today, since being mindful of time, I picked a small topic, which is the latest update from Therapeutic Guidelines. It's called Obstructive Sleep Apnea. Previously, it was mentioned in the Therapeutic Guidelines, but not much in detail. But in the current version, they have mentioned quite clearly. There are many details they've given us about assessment and how to manage, which is quite informative, and I think it will be useful for your exams. Before we start, I would like to thank everyone for following my videos, and at the same time, it would be helpful if you guys can share my videos and subscribe to my channel. Thanks. Now let's get started. Now, as an introduction, sleep disordered breathing, what does it mean? So we need to understand the disorders breathing. Basically, sleep disorder spectrum refers to primary snoring to a complete obstructive sleep apnea. And obstructive sleep apnea, uh, they're, they vary with partial airflow reduction, which is called as hypopnea, and total cessation of breathing, which is called as apnea. There are certain comorbidities which contribute, such as hypertension, atrial fibrillation, heart failure, and cognitive delay. Now, as dental professionals, our role is to identify, screen the patient, and if required, we can advise a mandibular advancement splint. Now, we'll get into details about when we can advise the mandibular advancement splint and all those things as we keep going forward. Now, there was some specific mentioning about pharyngeal collapse during sleep. So, you got our pharyngeal muscles during sleep. What will happen is these muscles tend to relax, and that sort of causes some airway obstruction. Now, what's happening because of the pharyngeal collapse is there are certain events which are taking place. There is decrease in the oxygen saturation. There is sleep fragmentation, which means you're not having proper sleep, which in turn leads to daytime sleepiness. It's sort of like this, where you think you slept for about 8 hours or 7 hours, and then in the morning you realize you're still feeling tired. That's possibly because of the pharyngeal muscle collapse. And also there is an indication which was mentioning about increased cardiac workload. So when there is reduced oxygen supply, what's happening is your heart muscles trying to pump more blood in order to supply oxygen, and thereby there is increased cardiac workload as well. So there's risks associated which range from moderate to severe. Uh, Severe being premature death or times having a medical episode like stroke. Now there is apnea's hypopnea index which been mentioned, and it basically averages based on the events per hour of sleep. Now there is this range which has been given. It's worth knowing it. Now, if there are less than 5 events in adults, that means there is not much clinical impact. Mild is considered if there are about 5 to 14 events. Then you can make in your clinical notes that there is symptomatic or mild. If it's a moderate obstructive sleep apnea, there are about 15 to 29 events per hour. That means there is a risk of systemic health factors, right? And 30 or more means there is a risk of cardiovascular complications. So if you're one of those who are using the latest smartwatches which detect which sort of track the sleep. At the same time, there are some good ones which actually detect the oxygen concentration as well. So those provide a bit of this information in detail. Now, screening. What predominantly they're saying is these are the target populations. So people who are over 50 years, that's one. Now, that doesn't mean in all cases, all right? So you have to pick any risk factors which are pointing towards obstructive sleep apnea. There have been clear mentioning about BMI, which is more than 30 kilogram per meter square, obese individuals. If a patient comes to you with a history of hypertension or diabetes, yeah, they are one of the target populations. Excessive alcohol users, they are also target populations. People coming with symptoms such as snoring, choking, or their partners witnessed apneas during sleep, then they are also the target populations. So there are various screening tools used. So you, as a dental professional, we are just having some valid questionnaires, uh, and they are only helping us as a guide. They are not giving us any conclusions about sleep apnea. So it's been clearly mentioned that questionnaire scores do not diagnose obstructive sleep apnea. They sort of indicate the severity, and you're sort of referring the person, deciding on referring the person to the medical sleep study, or depending on the patient. There is these two notes given in the therapeutic guidelines. That is basically a screenshot from the therapeutic guidelines, which is snoring, which resulting from vibrations in the pharynx during breath while asleep. It is common and can affect people on all ages, but is particularly prevalent in middle age. The risk of snoring is increased by factors that narrow the pharyngeal space, relax the pharyngeal muscles. Now, this is important. Over 10% of regular snorers have sleep apnea. Now, if there's a question, which is sometimes they give community based questions and ask which of the following statements is correct. So there is some statistics which has been extracted from therapeutic guidelines. So you remember this point. Next comes the severity of obstructive sleep apnea is measured by apnea hypopnea index. The AHI it gives the average number of apnea events. So as we discussed earlier in the table, that was the events we were talking about. Now there is specific reference about neck circumference. Now there's not been mentioning about any geographical distribution or age or anything. It's just a simple measurements given classifying as males and females. If an adult male neck circumference is more than 42 centimeters, they are at risk. Similarly, if an adult female neck is more than 39 centimeters, they are at risk of pharyngeal collapse. Now, what are the intraoral risk factors? So, developmental skeletal deformities like micrograthia, retrognathia, narrow, high arched palate. Apologies here, it's a narrow palate and high arched palate. That's a skeletal deformity. They've been mentioning about soft tissue considerations, especially in children with Down syndrome, because children in Down syndrome have macroglossia most of the times. So that's been specifically mentioned as a risk factor, and children having adenotonsillar hypertrophy. tonsillitis, and nasal septum deviation. If any kids got it, that's considered as an intraoral risk factors. Now have a look here. Again, this is from TG. Macroglossia in Down syndrome carries a prevalence of nearly 100% of for obstructive sleep apnea. So 100%, which is a sure short thing. So in these patients, you have to refer for medical evaluation. In all, I mean, is basically what they're saying is all Down syndrome patients should be referred for medical evaluation. Next comes the referral process. Now, where are we referring? That's a big question and confusing aspect all the time. In general, you're referring to a GP if a questionnaire scores or a clinical feature suggest obstructive sleep apnea. Okay, straightforward. In your questionnaire, yes, in your questionnaire they say it's obstructive sleep apnea. Refer to GP. We are not diagnosing it. There is a possibility there. Sleep physician referral is done when there are complex presentations like medical conditions like heart failure, significant respiratory diseases, and symptomatic patients who don't meet questionnaire thresholds. These ones you're referring to the sleep physician. Now, children, we are referring them to the pediatric dentist or sleep physician or ENT specialist. In general, it's worth noting that multidisciplinary team management is ideal in managing patients. Especially in children, you can involve pediatric dentist and orthodontist. Now let's look into the management. Yeah, this thing is self-explanatory. You can look at weight loss, smoking cessation, reduction of alcohol, use of intranasal corticosteroid, nasodilator strips, positional therapy devices, and gold standard is CPAP, which is referred to as continuous positive airway pressure. General dental management is by use of mandibular advanced splints or appliances, tongue retained appliances. They specifically mention that tongue retaining appliances are not recommended. So if an option comes up between these two, stick to mandibular advancement appliances. And surgical operation options such as adenotonsillar ectomy, palatal surgeries, or orthodontic surgeries. Now, when we look at the mandibular advancement splints, how they work is by protruding the mandible, and by protrusion of the mandible, what will happen is it will stabilize the soft tissues and open up the pharyngeal airway. That's how they work. Generally, it's recommended mandibular advancement splint in mild to moderate obstructive sleep apnea cases. In severe cases, generally patients will go for CPAP. Now, if there is a condition where CPAP is not tolerated, then we can recommend mandibular advancement splints. Complications and informed consent. This is important because it comes under code of ethics about consent, informed consent. So you just got to be mindful about if it's a child patient, how are we managing? If it's an adult, how are we managing? If it's an adult with uh, intellectual disability or limited understanding capability, how are we managing? Those things are discussed in a different area. I will certainly cover those things because it's quite confusing, and if you're reading it takes a while to thoroughly understand that. I will break it down and explain you in the upcoming videos. Now, there are certain mandibular advancement risks which have been mentioned, but occlusal changes is one of the major risks which has been specified. Hypersalivation or a dry mouth, we can't use them. Temporomandibular joint exacerbation or initiation could happen. There could be a fractured teeth or restorations. Now, after this, I've got some quiz for you guys. Now, based on what we read, the usual drill, I'll leave a I'll leave the slide on for 10 seconds. The next slide will be your answer. Please try to answer by yourself. If you if you think I'm too fast, just pause the video, have a think, and then answer in your mind, and you can check the answers. I would like to mention that these answers are from therapeutic guidelines, as mentioned in the therapeutic guidelines. I didn't make up anything, nor copied from elsewhere. All the best, guys. Well, that finishes the discussion for today. I hope you found some value out of this. Again, I would like to mention, please like, share, and subscribe for further updates, and I'll be making more based on the therapeutic guidelines. Thank you.